Welcome back, everyone. We're going to continue down the obstetric series with the stages of labor and routine childbirth. The first stage of labor begins with the onset of labor pains and lasts until the cervix is fully dilated. It's hallmarked by the rupture of the amniotic sac near the end of the stage. The second stage of labor begins as the head descends and to enter the birth canal. The fetus will undergo several positional changes, including internal rotation, extension, rotation to the side, and then movement of the shoulders. Contractions are more intense and frequent during the second stage of labor, and the cervix becomes fully dilated. This stage concludes when the newborn is fully delivered. The third stage of labor is the expulsion of the placenta. The placenta is expelled, and the uterine contracts and squeezes to shunt the exposed blood vessels and control hemorrhage. Generally, the first stage of labor can last 8 to 12 hours for a nullipara patient, meaning first pregnancy. The second stage, 1 to 3 hours, and the third stage, anywhere from 5 to 60 minutes. As you'll note, as the patient has more pregnancies, labor tends to progress faster. So for a multipara patient, that first stage of labor can be anywhere from 6 to 8 hours. The fetal and maternal response to labor. For the maternal response, there's an increase in workload of the heart, blood pressure, pulse, and cardiac output, an increase in breathing rate, an increase in white blood cell production, and protein breakdown. As far as fetal response during childbirth, there is a decrease in the amount of oxygen and nutrients. They don't have a good capacity to remove waste as the placenta has detached from maternal circulation. It's not uncommon to see fetal heart rate diminish or decrease, and fetal acidosis is also common. In preparation for delivery, there are lots of positions for mom to deliver the infant. Lying supine is the most common position in the West, although it's not always the most appropriate position to deliver a childbirth. We call this the lithotomy position. The reason being is the symphysis pubis creates a significant arch or bend in the birth canal, and this can oftentimes complicate delivery to some extent. So during the birthing process, it may be prudent for mom to roll over on her hands and knees, to stand or squat during childbirth, or lie in the recumbent position to help facilitate passage of baby through the birth canal. When you're preparing for delivery, you'll have an OB kit or should have an OB kit at your disposal. Make sure that you wash your hands, you put on gloves, and maintain standard precautions. Drape the woman in sterile towels and try and create a clean area for the birth to occur. When assessing whether or not to deliver in a pre-hospital world, it's going to depend on the frequency of contractions and the progression of the phases of labor. General assessment, you'll want to assess for crowning or a bulge of the vulva during the contraction process, and look for any head, scalp, or any of the limbs presenting can help determine how imminent delivery is going to be. The worst place to deliver a baby is en route to the hospital. Next best choice would be to deliver that at home, with obviously the most appropriate for EMS considerations would be for mom to deliver in a facility. However, if delivery is imminent, you need to prepare the home space and prepare for childbirth at home. Make sure that you have a safe, controlled environment, and that having your partner at the woman's head can help provide some comfort and reassurance, but make sure that you include family if family wishes to be in the room. Cultural considerations are also important here. It's not uncommon for other cultures to have what may appear to be strange birthing cultures to Western citizens. And what I mean by that is, don't be surprised if father is not allowed in the room or dad isn't allowed in the room during the birthing process, or the family is removed, or it may be a celebration culture where everybody is in the room. Your communication should be with mom, and mom should be made to be comfortable whatever that may be. So your communication with mom or your partner's communication with mom while you're assessing and preparing for delivery is crucial to ensuring an adequate environment where the most successful environment or the most successful childbirth can occur. Keep calm. There's a lot of panic associated with childbirth and prehospital providers. Remember that most of the time, childbirth is normal. This is a normal process of human life, and it should be celebrated and is not something to necessarily be concerned with. As a trained provider, you should have an index of suspicion and be aware of things that can go wrong. But by and large, birthing is a very normal process that requires little intervention. As baby starts to move down the birth canal, you want to control delivery. Support the head. You're not putting pressure on the head, not pushing back into the birth canal, but support the head as it emerges. Once the head passes through the vaginal opening, you want to evaluate for a nuchal cord or a cord around the neck. And if there is a nuchal cord, you can oftentimes just loop it back over the head so that it's no longer problematic. Don't tug on the umbilical cord. And if the umbilical cord is preventing delivery of baby, then that would be a time when you need to consider transport and communication. That's fairly rare and uncommon, but it is something to be considered of. Once the head is delivered, you want to clear the airway by suctioning with a bulb syringe. We generally encourage you to suction mouth first and then nose. Favoritism tends to alternate between those two, and as long as you're clearing that airway, it's okay. As the head becomes delivered, you'll note that the baby rotates usually 90 degrees, and you're going to gently guide the head downward for expulsion of the superior shoulder, so the shoulder that's at the top, and then gently guide the head upward to allow the passage of the lower shoulder or the inferior shoulder. Once the shoulder is delivered, baby's going to slide out really quickly, so make sure you're holding on and caring to not drop baby on the floor during this process. Once the shoulders pass, that's kind of the last obstruction, and the trunk and legs will follow rapidly. Once delivered, maintain the newborn at the same level of the vagina. Wipe blood and mucus from the newborn's mouth and nose with sterile gauze, and then you should begin to dry and warm neonate. The number one consideration for baby post-delivery is temperature management. Keep baby warm. So keep baby at the level of the vagina, warm with towels, get covered up, dry the baby off, and then once you have dried baby, you can place baby on, oftentimes mom's stomach is a good place while you clamp and prepare to cut the cord. You should clamp the cord before elevating the baby too far because the blood flow is still attached to the placenta, and we want to try and prevent sort of backflow of any of those blood materials to reduce fetal circulation. Some birthing practices now encourage delaying to clamp the cord. As far as us in the prehospital world and our evidence of practice, we're generally going to clamp and cut the cord relatively quickly. Dry the newborn with sterile towels, wrap in a dry blanket. Make sure you record the time at birth. You're also going to need to get an APGAR score for baby during the first minute of birth. APGAR is a relatively subjective, but it's what we use as sort of a standard gauge for baby's improvement post-delivery. It consists of appearance, pulse, grimace, activity, and respiration. APGAR is yet another acronym. Appearance, blue or pale skin color will be 0 points. If they have a pink body but blue extremities, they get 2 points. If they get, or 1 point if they're completely pink, they get 2. Babies aren't born pink. Most babies have some amount of cyanosis or pallor. That's common. It's usually in the extremities, but it's not uncommon for it to be truncal or central as well. Pulse is just going to be over 100, over 100, and absent. Grimace is the reflex irritability. So as you're drying baby, are there kind of pulling away or is there muscle tension there? If there's not, if they're flaccid, then it's 0 points. If they're have minimal response to stimulation, you're going to get 1, and 2 would be a prompt response, and then you have activity, which is the flexion of the arms and legs, or kind of contracted inward, or active, are they moving around significantly? And then respirations are either absent, slow, or irregular, or a vigorous cry. And you're going to want to get this score relatively early because you're going to take this score again later to gauge how baby is progressing. You generally want to get it at minute after birth and then 5 to 10 minutes after birth as well. Most newborns are going to get a score somewhere between 7 and 9, and an infant with a score of 4 to 6 may be a candidate for resuscitation. All right. Cutting the umbilical cord, make sure you handle the cord with care. Tie or clamp the cord with 2 clamps, usually about 2 inches apart, and then cut the cord in between them. Examine the ends to ensure there's no bleeding. Once the cord's cut, wrap newborn in a dry blanket and hand to mom, and encourage. Once you've done your initial APGAR assessment and baby is vigorous and crying, you need to hand to mom to encourage breastfeeding for that secretion of oxytocin. One that will help the contractions to expel the placenta and start to control that hemorrhage process. Once baby has been delivered, you've performed your assessment, you've got sort of mom wrapped up and ready to go, you're fine to go ahead and initiate transport. Remember, you do still have the 3rd stage of labor here where you need to, the placenta is going to need to deliver. I would encourage you to wait long enough if it's not an emergent transport or there's not been a complication, to ensure there's not complications with the placenta delivery, or the patient's not having multiple babies. There's not twins or triplets and so forth. Placenta usually delivers within 30 minutes after delivery of the baby. Don't pull on the umbilical cord to try and facilitate that. Just encourage mom to breastfeed and instruct the patient to kind of bear down and push, and that will help deliver those products. The placenta, the fetal side, you should inspect the placenta, and it should be transported with you to the facility. The fetal side should be a gray and shiny color. It's smooth, and the maternal side is typically a dark with a rough texture. Place the placenta in a bag and examine the perineum as well for any lacerations in the perineal tissue. Make sure you get mom's vital signs, monitor mom's condition closely. Watch for things like hemorrhagic shock, seizure activity, or respiratory difficulty. Post-delivery, we're concerned with things like emboli, pulmonary emboli, lung activity, seizure activity, and then, of course, hemorrhage or shock from blood loss. You should assess the fundus, and you may need to help facilitate contractions of the uterus post-delivery. There's going to be a significant amount of blood loss. Remember that the body prepares for that with some blood, but extended hemorrhage time or extended fluid loss, and that's generally interpreted as fluid loss greater than 500 milliliters of fluid during the birthing process. You may need to conduct a fundal massage, which is where you place your hand, the lateral portion of your hand at the symphysis pubis, and come over just the top of the symphysis pubis and massage upward the uterus to facilitate that contraction to help stop the hemorrhage that's present post-delivery. Make sure you keep mom warm when you're assessing the fundus. Note the lochia, which is the top of the fundus or the fundal height. It's usually going to be at about the umbilicus for the first 24 hours, and then it's slowly going to contract downward back in behind the symphysis pubis and back to its sort of normal pre-pregnancy shape and structure. As far as pharmacologic agents in pregnancy, remember that maternal physiology changes can have an impact on pharmacy therapies. So if you need to engage in pharmacologic treatment, you need to be aware of these changes. Higher doses might be needed, and indications can pass quickly, or medications can pass quickly from maternal to fetal systems. So make sure that you're aware of what you're giving and have the appropriate medication if it's needed. Some of the medications that we'll use, and this is specific to AEMTs and paramedics. Some of these are just paramedics. Some of them are AMT and paramedic both. Most of these medications, with the exception of oxygen, is going to be withheld at the EMT level. So we'll talk about some of the medications that are common for gravid patients. First of all is magnesium sulfate. This is used in pregnancy to manage eclampsia or seizures in the pregnant patient. can cause respiratory depression, hypotension, and circulatory collapse. Although those side effects are very, very rare, magnesium is a relatively safe drug when given appropriately. Calcium chloride is used to manage hypocalcemia. You can have some side effects, including nausea, vomiting, syncope, bradycardia, and dysrhythmias if it's excessive. Terbutaline or breathine is administered to suppress preterm labor. It's also used in hospital or long-term care to treat pregnancy-induced asthma and as an antitocolytic, which means that it'll suppress pregnancy. We generally don't stop labor in the pre-hospital world. There may be some isolated services in areas where we consider the utilization of a medication to stop an early preterm labor, but to best of my knowledge, this is not a practice that we engage in the pre-hospital world. You may see terbutaline on an ambulance given as a tertiary or secondary or tertiary respiratory medication for non-gravid patients, but its function in the pregnancy world is for suppressing preterm labor. Valium is indicated for eclampsia when the seizures are not managed by magnesium sulfate. Remember that our first-line treatment for seizures in the pregnant patient is going to be magnesium because of the pregnancy classification of the benzodiazepine class. Side effects for this include nausea, vomiting, respiratory depression, and hypotension. Diphenhydramine is an antihistamine used to treat hyperemesis gravidarium. If you'll recall, that is the excessive nausea and vomiting that can lead to dehydration and malnutrition in the gravid patient. Side effects include drowsiness, headache, tachycardia, and hypotension. Oxytocin is known by the brand name Pitocin, and it's a medication that's a naturally occurring hormone that causes uterine contractions. This is used to induce labor in the hospital, and in the pre-hospital world, we'll use this to control postpartum hemorrhage. So as I mentioned during the normal pregnancy, encourage mom to nurse baby. That releases the natural occurrence of oxytocin and helps the uterine contract. In cases of uncontrolled post-delivery hemorrhage, vaginal hemorrhage, where there's not enough oxytocin present, or we can't get hemorrhage controlled through other measures, whether that be the natural process or by fundal massage, we may consider the use of oxytocin in the pre-hospital world. It is a titrated administration because each response to each patient is going to be a little bit different. It's usually 10 to 20 units IV in an infusion bag, and then we're giving that over a period of time and sort of moving up and down depending on the patient's tolerance. As you increase the administration of oxytocin, you're going to increase the force of contraction. Your goal here is to stop hemorrhage, not increase pain and discomfort necessarily. Side effects for oxytocin include nausea, vomiting, tachycardia, seizures, and cardiac dysrhythmias.